Now, we are going to talk about polyhydramnios. So first, the definition of polyhydramnios. Tell me, in polyhydramnios, what is the AFI? AFI is more than equal to 25 centimeters. Single largest vertical pocket is more than equal to 8 centimeters. And the absolute value of amniotic fluid is more than equal to 2 liters. Now, when am I going to see polyhydramnios? I'm going to see polyhydramnios because urine is the main contributor. So whenever there is excessive urine production, I'm going to get polyhydramnios, and excessive urine production is going to happen in multifetal pregnancy. Multifetal pregnancy. Number 2, it is going to happen not only in multifetal pregnancy, in twin-to-twin transfusion syndrome. Please remember, in twin-to-twin transfusion syndrome, one fetus is going to have polyhydramnios, the other twin is going to have oligohydramnios. So twin-to-twin transfusion syndrome will be included both in causes of polyhydramnios and in causes of oligohydramnios. Third condition which leads to increased urine production is maternal diabetes. Maternal diabetes is going to lead to increased urine production. How? See, whenever there is maternal diabetes, that means there is maternal hyperglycemia, and fetus for all its glucose needs is completely dependent on the mother, right? So whenever there will be maternal hyperglycemia, this glucose from the mother definitely has to come to the fetus. So there will be fetus hyperglycemia. Right? And because of this fetal hyperglycemia, all of you know that whenever there is hyperglycemia, there will be polyuria. Right? So the third condition where you get increased urine production which leads to polyhydramnios is maternal diabetes. You will get increased urine production in fetal high cardiac output states. In fetal high cardiac output states also there is polyuria. Obviously, if there is a high cardiac output, there will be increased blood flow to the kidney, and if there will be increased blood flow to the kidney, there will be increased GFR. In other words, there will be polyuria. So what did I say just now? I said whenever there is increased cardiac output by the fetus, what is it going to do? There will be increased renal blood flow to the kidney. There will be hyperperfusion of the kidney. And whenever there is increased blood flow to the kidney, there will be increased GFR, and that is going to lead to polyuria. Now, what are the conditions which lead to high cardiac output? Number 1, high cardiac output is seen in cases of fetal anemia. Whenever there is fetal anemia, it leads to high cardiac output. Now, what are the conditions which lead to fetal anemia? One infection which leads to fetal anemia is parvovirus B19 infection. I'm sure you have read this in microbiology that parvovirus B19 infection leads to fetal anemia. Number 2, if there is alpha thalassemia. So, if the fetus has got thalassemia or if the fetus has got G6PD deficiency, right? Or if there is arteriovenous shunting, and this arteriovenous shunting again is seen in twin-to-twin transfusion syndrome. It is seen in sacrococcygeal teratomas, and it is seen in chorangioma of the placenta, right? So AV shunting is seen in twin-to-twin transfusion syndrome, it is seen in sacrococcygeal teratoma, and it is seen in chorangioma of the placenta. So all these things lead to fetal anemia, and because of fetal anemia, there is going to be polyuria. Another reason for high cardiac output is whenever there is fetal heart failure. So whenever there will be fetal heart failure, you are going to get high cardiac output, which is going to lead to polyuria. Now, what are the conditions in which you get heart failure? A very, very important condition in which there is fetal heart failure is hydrops fetalis. Hydrops fetalis. Now, in hydrops fetalis, why hydrops fetalis occurs? One of the very important reasons for hydrops fetalis is Rh isoimmunization. Right? Other reason for hydrops fetalis again is parvovirus B19 infection. So parvovirus B19 infection is leading to polyuria due to fetal anemia, due to hydrops fetalis and torch infections. Right? So all these conditions can lead to polyhydramnios. Now, please remember that like I told you, twin-to-twin transfusion syndrome, it can be a cause of oligohydramnios and polyhydramnios. Similarly, torch infections can be a reason for polyhydramnios and oligohydramnios. How? See, just now I told you that torch infections, they can lead to hydrops fetalis, and because they can lead to hydrops fetalis, that is why they can lead to polyhydramnios. On the other hand, if you go back to the place where I was explaining to you about how does placenta affect amniotic fluid? One thing I told you that whenever you will get a small placenta, you are going to get decreased amniotic fluid. Now, it is not necessary that the placenta has to be small to decrease the amniotic fluid. Even if placental calcifications are present, right? So, if the placenta is calcified, that also leads to a decrease in filtration of the maternal plasma. And that can also lead to oligohydramnios, and calcification of placenta is seen in torch infections. So torch infections, bacho, is one cause which can lead to both oligohydramnios and it can lead to polyhydramnios. Right? So write down. Two causes which can lead to oligohydramnios and polyhydramnios are twin-to-twin transfusion syndromes and torch infections. In torch infections, oligohydramnios is more common than polyhydramnios, but yes, both can be seen. Clear to all of you? In few infections, sometimes you may get oligo and sometimes you may get poly. But more common presentation is oligohydramnios. Have I made myself clear to all of you why oligohydramnios happens in torch infection and why polyhydramnios can happen in torch infections? Yes? Okay. If there are fetal kidney disorders, they may also lead to polyuria. Now you are going to say that, ma'am, fetal kidney disorders, they lead to oliguria and not polyuria. But bacho, there are two fetal kidney disorders which lead to polyuria rather than oligouria. Right? And that is why I always keep on telling you that please do not mug up your things. Try to understand the concept. Now over here, what is going to happen in both these conditions, what you're going to see that the kidney is going to get increased blood flow. There will be hyperperfusion in the kidney, and because of hyperperfusion in the kidney, there is going to be polyuria. Right? If there is a defect in the kidney so that kidney is unable to produce urine, that will lead to oligouria, and that is going to lead to oligohydramnios. But if there is a problem which leads to excessive blood flow to the kidney, that is going to lead to polyuria, and that is going to lead to polyhydramnios. Same thing happens in congenital mesoblastic nephroma. Whenever there is a congenital mesoblastic nephroma, there is hyperperfusion of the kidneys, and because of increased renal blood flow, there is increased GFR. In other words, there is polyuria. The other condition which you have to remember is a very, very important syndrome which leads to polyhydramnios, and that is Barter's syndrome. Now, Barter's syndrome is a congenital defect in the kidney, and Barter's syndrome you have studied in your medicine lectures where you see that there is polyuria and salt wasting. Right? So Barter's syndrome, one of the variants of Barter's syndrome is an X-linked recessive disorder. So suppose you have a pregnant female who's carrying a male fetus and suddenly there is unexplained severe polyhydramnios which is happening in second trimester. T2 when I write, it means it is second trimester. When I write T1, it is first trimester. And when I write T3, it is third trimester. Right? Clear? So if you are getting suddenly in a pregnant female who's carrying a male fetus, you see that there is, severe polyhydramnios, you should always think about Barter's syndrome. Right? So till now, I have discussed with you only one mechanism for polyhydramnios, and that one mechanism for polyhydramnios was increased urine production. So all the causes which I have told you for polyhydramnios just now, all of them, the basis of polyhydramnios in all of them was increased urine production. Now, not only increased urine production, but polyhydramnios can also happen due to fetal swallowing defects. So the second mechanism which can lead to polyhydramnios is a fetal swallowing defect. Now, I was telling you that a fetus not only produces urine, it keeps it in balance by swallowing it. So, whenever there will be a swallowing defect, it is going to lead to polyhydramnios. Now, this swallowing defect could be a primary swallowing defect, or it could be that due to pressure on the esophagus, swallowing is not happening. Right? Now, primary swallowing defect, it is seen in cases of duodenal atresia, esophageal atresia, cleft lip, cleft palate, and neural tube defects. In neural tube defects, there is a swallowing defect also. Right? And a secondary swallowing defect, that means there is pressure on the esophagus because of which a fetus is not able to swallow. It will be seen in thoracic masses and in congenital diaphragmatic hernia. Right? So they can lead to a secondary swallowing defect. For that matter, goiter, that is thyrotoxicosis, can also lead to a secondary swallowing defect. Right? So swallowing defects in the babies can lead to polyhydramnios. Now, let me integrate OBS and surgery for you over here. Duodenal atresia, Dr. Rohan must have taught you, right? And he must have taught you that what is the most common sign which you get on duodenal atresia when you do an ultrasound. What sign do you get in duodenal atresia? You get a double bubble sign. Double bubble sign, a bubble related to stomach and a bubble related to the duodenum, right? Now, duodenal atresia, please remember it is associated with Down syndrome. In Down syndrome, yes, you get duodenal atresia. So these are 2 points which you're going to remember about, 3 points rather about duodenal atresia. Duodenal atresia leads to polyhydramnios. In duodenal atresia, on ultrasound, you get a double bubble sign, and duodenal atresia is associated with Down's syndrome. Is this clear to all of you? Now, these 3 points can be twisted in the form of a clinical based question and they can ask you. So just let me ask you a clinical based question where all these points have been combined together and a clinical vignette has been made. So there is a 25-year-old primary patient who is presenting for routine antenatal examination at 20 weeks. On per abdominal examination, her fundal height corresponds to 24 weeks. Now please tell me, in polyhydramnios, when you are going to do a per abdominal examination, what are you going to get? When you do a per abdominal examination, height of the uterus is more than the period of gestation. And when should you suspect that you are dealing with the case of polyhydramnios? When height is more than 3 weeks ahead of gestation. So if on per abdominal examination, height of the uterus is more than equal to 3 weeks ahead of gestation and you were doing it on a patient who had emptied her bladder, her menstrual history is absolutely normal, then you should suspect that this is a case of polyhydramnios. Right? So the obstetrician, that is why, refers the patient for ultrasound because she wants to see whether amniotic fluid is in excess or not. On ultrasound, the following image was obtained. So this was the image which you are getting on ultrasound. You are seeing a bubble over here and you are seeing a bubble over here. This is what is a double bubble sign. Right? Now they are asking you what is the next step in management. Now, whenever you are getting, whenever you have a patient of polyhydramnios and it is moderate or severe, and on ultrasound you get congenital anomaly is seen, then please remember the next step is always you should go for karyotyping. You should always go for karyotyping because chromosomal anomalies are, all the cases of polyhydramnios or oligohydramnios, whether it is polyhydramnios or whether it is oligohydramnios, moderate or severe polyhydramnios or oligohydramnios with gross congenital anomalies. So if they have gross congenital anomalies, they have increased risk of chromosomal anomalies also. Chromosomal abnormalities also. Right? And that is why in all these cases you should do karyotyping. Right, so in this case, I am seeing a double bubble sign, and double bubble sign is associated with Down syndrome. So my next step should be I should go for karyotyping to rule out Down's syndrome, right? Because duodenal atresia has a very high association with Down syndrome. Is this clear to all of you? So this is a rule which you have to remember, that whenever you have a patient of moderate to severe polyhydramnios or oligohydramnios and you do an ultrasound, and on ultrasound you can see that gross congenital anomalies are present, then in such fetuses there is increased chances of chromosomal abnormalities, and always the next step has to be karyotyping. But on the other hand, if there is no gross congenital anomaly, then there is no need to do karyotyping, right? Karyotyping should be done only if on ultrasound you can see gross congenital anomalies, right? My next question is, if they ask you what is the most common cause of mild polyhydramnios, most common cause of mild polyhydramnios is idiopathic. Most common cause of moderate or severe polyhydramnios is congenital anomalies of the fetus. And which congenital anomaly? GI anomaly. GI anomaly leading to swallowing defects, right? So the most common congenital anomalies, the most common cause of moderate to severe polyhydramnios is congenital anomalies. And which anomaly? GI anomaly. Most common cause of mild polyhydramnios, that is idiopathic. Right? Okay. Now, I was telling you, we were talking about the mechanisms which can lead to polyhydramnios. One mechanism was increased urine production. Second mechanism was your fetal swallowing defect. Now, third mechanism. Third mechanism is increased transudation across fetal skin. I'm writing it here if you cannot read orange color. So, increased transudation across fetal skin. And increased transudation across fetal skin is going to happen in all those conditions where there is a skin defect, right? So, neural tube defects and abdominal wall defects like omphalocele and gastroschisis. Now, please remember there are a lot of differences between omphalocele and gastroschisis which you should be aware of, and I have covered them in OBGY and radiology integration. Right? Then there are unknown mechanisms. Now, in unknown mechanism comes trisomy 18. In trisomy 18, you get IUGR plus polyhydramnios. So, if you are getting IUGR plus polyhydramnios, you should suspect trisomy 18. This is typical. Why have I written it as typical? See, just now I was telling you that IUGR leads to uteroplacental insufficiency. That leads to a small placenta, and small placenta leads to oligohydramnios. right? But this is one condition, trisomy 18, in which you are getting IUGR and polyhydramnios. So this combination is rare to find. Right? IUGR and oligohydramnios always you get. But if you are getting IUGR and polyhydramnios, that means it is a case of trisomy 18. Clear to all of you? But what is the mechanism? That is unknown. Right? So these are the basic reasons for polyhydramnios. You don't need to mug up these reasons. Because I have explained you the mechanism behind them, now when you are going to see them in the options, you will understand whether in that particular case polyhydramnios is going to happen or it is not going to happen. Right? Now, what are the problems which can happen due to polyhydramnios? See, in polyhydramnios, there will be over distension of the uterus. Now, because of the over distension of the uterus, number one, there can be respiratory difficulty because the uterus is going to push the diaphragm up. Because of over distension of the uterus, when the uterus is overstretched, it can lead to preterm labor. How over distension leads to preterm labor? In the video on preterm labor, I have explained to you in detail. Then over distension of the uterus can lead to premature rupture of membranes. Preterm premature rupture or premature rupture of membranes. Obviously, suppose there is a balloon and if you keep on filling water in it, ultimately a time is going to come when the balloon will burst. Same is the case here. Polyhydramnios means there is excessive amniotic fluid. Ultimately, one day the membranes are going to rupture, and that is what is preterm premature rupture of membranes or premature rupture of membranes. Right? Then, because of the over distension of the uterus and because of PROM, what can happen? See, in patients of polyhydramnios, because the uterus is over distended. Now, sometimes or the other, the membranes have to rupture because of over distension. Now, when the membranes are going to rupture, the entire amniotic fluid is going to come out suddenly. So, the size of the uterus will suddenly shrink. Now, because the size of the uterus will suddenly shrink, the placenta which was attached to the uterus is going to separate, and that is what is called as abruptio placenta. I'm repeating. In polyhydramnios, there is over distension of the uterus, right? So ultimately, the membranes are going to rupture because of over distension, and whenever the membranes are going to rupture, the entire amniotic fluid is going to come out suddenly, and so the size of the uterus will suddenly shrink. So the placenta which was attached to the uterus is going to get detached, and that is what is called as abruptio placenta. Right? And the fourth problem with which polyhydramnios can lead to is that after delivery, this over distended uterus which has lost its tone due to over distension is going to bleed. Right? So it can lead to PPH, postpartum hemorrhage. Right? So because of over distension, preterm labor can happen, premature rupture of membranes can happen, abruptio placenta can happen, and because the uterus is over distended, its tone is decreased, so it will continue to bleed after delivery, and that is what is postpartum hemorrhage. Not only this, what happens is because the uterus is over distended and there is a lot of amniotic fluid, so fetus keeps on changing its position. Right? So sometimes the fetus is cephalic, sometimes it is breech, and that is what is called as unstable lie. So polyhydramnios can lead to unstable lie. Polyhydramnios can lead to malpresentations. So these are all complications which can happen with polyhydramnios. Right? Now, how do you manage a patient with polyhydramnios? Please remember, if the patient is asymptomatic or if she has mild symptoms. What mild symptoms? She has mild respiratory discomfort, she has mild uterine irritability, then no treatment is done. Patient doesn't need any treatment. So if there is asymptomatic polyhydramnios or mild polyhydramnios, no treatment is needed. Treatment is needed only if patient has severe polyhydramnios. And how do you classify severe polyhydramnios? Severe polyhydramnios means if the single largest vertical pocket is more than equal to 16 centimeters, or if amniotic fluid index is more than equal to 35 centimeters. Polyhydramnios was single largest vertical pocket more than equal to 8. So if it becomes double, right? So if from 8 it is becoming 16, it is severe polyhydramnios. AFI normal was, polyhydramnios mein AFI was more than equal to 25. Now if it becomes more than equal to 35, then that is severe polyhydramnios. So if your patient has got severe polyhydramnios, and along with severe polyhydramnios, she has shortness of breath which interferes with her day-to-day life, and there is uterine irritability, then treatment is needed. So what is the indication for treating a patient with polyhydramnios? Severe polyhydramnios characterized by single largest vertical pocket more than equal to 16 centimeters, AFI more than equal to 35 centimeters, along with shortness of breath which is interfering with her day-to-day life, and uterine irritability. That is when treatment is needed. Now, what treatment are you going to do? In treatment, I am going to go number 1 for amino reduction. Right? Now, amino reduction means you are taking out amniotic fluid by doing amniocentesis. So, amino reduction means you are taking out amniotic fluid by doing amniocentesis. This amniocentesis now becomes therapeutic amniocentesis. Indication of doing amino reduction is if patient has severe respiratory discomfort. And I told you, how do you say it is severe? If it is interfering with day-to-day life, right? The advantage is patient's respiratory discomfort is immediately relieved when you do amino reduction. Right? But disadvantage is that fetus will continue to produce urine, right? So there will be refilling of amniotic fluid. Right? There is going to be refilling of amniotic fluid very soon. And apart from that, amniocentesis being done for polyhydramnios, which is a therapeutic amniocentesis, has its own set of complications. For example, the most common complication which you see when you do amino reduction is it leads to preterm labor or premature rupture of membranes. The most common complication, and that is why whenever I am doing amino reduction, I am going to give the patient short-term tocolytics. I am going to give, if you cannot read what I have written, I am writing it again. You are going to give short-term tocolytic. Short-term tocolytic means for 48 hours while you are doing the procedure. Right? Because the most common complication when you do amino reduction is it can lead to preterm labor or premature rupture of membranes. Apart from that, it can lead to intra-amniotic infection. It can lead to abruption and hypoproteinemia. So again, I'm writing it in big over here. It can lead to intra-amniotic infection. It can lead to abruptio placenta. It can lead to hypoproteinemia. Now, when you are doing amino reduction, there are certain technicalities which you have to keep in mind. When you do amino reduction, you do it under ultrasound guidance. You are going to do it with 18 gauge spinal needle, and in one setting you are going to remove 2 to 2.5 liters of amniotic fluid at the rate of 1 liter in 20 minutes. Right? So how much amniotic fluid in one setting? In one setting, I am going to remove 2 to 2.5 liters, not more than that, right? And at what rate? At the rate of 1 liter in 20 minutes. And while I'm doing this procedure, I'm going to give a short-term tocolytic to the patient. What tocolytic has to be given? Just now, next, I'm going to tell you what tocolytic has to be given. So this was if your patient came to you with severe polyhydramnios. There was severe polyhydramnios with the main complaint of respiratory discomfort. Now suppose your patient is coming with severe polyhydramnios with severe uterine irritability. So much so that it can lead to preterm labor. Right? Now the patient is coming to you not because of respiratory discomfort. She is coming to you because of severe uterine irritability. Obviously, I'm not going to do amino reduction because just now I told you that the main complication of amino reduction in itself is preterm labor. And this patient has come to you with complaint of preterm labor or severe uterine irritability. Right? So in this case, I am going to give tocolytics. Right? So I am telling you that in severe polyhydramnios, patient can come to you with two complaints. Either they can come to you with shortness of breath, which is interfering with the day-to-day life. If they come to you with shortness of breath with which is interfering with the day-to-day life, you are going to say, I'm going to do amino reduction. If your question says that there is polyhydramnios with preterm labor, right, then or severe uterine irritability, then your answer is going to be that I'm going to give tocolytics. Right? Now, this is a general answer that I'm going to use tocolytics. But depending upon the gestational age, I'm going to decide whether to give tocolytics or not and which tocolytic to give. Now, if my patient is coming at less than 32 weeks and she's saying she has polyhydramnios plus preterm labor at less than 32 weeks. So in this case, yes, I'm going to give tocolytic. Which tocolytic? I'm going to give endomethacin. Why am I giving endomethacin? Endomethacin is a tocolytic. That is why I am giving. The other reason is that just now, a few minutes back, I told you that drugs like ACE inhibitors and endomethacin, they decrease urine output of the fetus and they bring about oliguria. In other words, they are going to bring about oligohydramnios. This patient has polyhydramnios. So yes, endomethacin is very useful to her because it is going to decrease amniotic fluid. So I am going to give endomethacin, and because she has come to me at less than 32 weeks and patient may deliver at any time, so I am also going to give corticosteroid. Now, more about preterm labor, how to manage preterm labor, I have taught you separately in the video on preterm labor. Over here, I just want you to understand that if patient is coming with polyhydramnios and patient is coming at less than 32 weeks, then the tocolytic of choice becomes endomethacin, because endomethacin also has, effect of bringing about oligohydramnios. Right? If patient is coming between 32 to 34 weeks, now I am not using endomethacin. I will use nifedipine as a tocolytic. Not endomethacin. Why? Because endomethacin, when it is used beyond 32 weeks, not endomethacin, because endomethacin, if used at more than 32 weeks, it can result in closure of ductus arteriosus. Closure of ductus arteriosus, and this was your previous NEET question. That why is it that endomethacin should not be used beyond 32 weeks? Because it can lead to premature closure of ductus arteriosus. Now again, in this category also, I have to give corticosteroid. Corticosteroid should always be given whenever a patient comes to you with uterine irritability at less than 37 weeks. Right? So whenever a patient comes to you with preterm labor or uterine contractions which are happening at less than 37 weeks, you should always give corticosteroids. Corticosteroids should always be given in preterm labor or uterine irritability which is happening at less than 37 weeks, right? Next point. Tocolytics should not be used at more than 34 weeks. So at more than equal to 34 weeks, you are not going to use tocolytics, and endomethacin should not be used at more than equal to 32 weeks, right? So between 32 to 34 weeks, I will still give tocolytics, but my choice will now be nifedipine. It will not be endomethacin, even if patient has polyhydramnios, right? Beyond 34 weeks, no tocolytics. Even if she is having uterine irritability, no tocolytics, just corticosteroid. Clear to all of you? So this is how you manage a patient of polyhydramnios who comes to you, severe polyhydramnios, who comes to you with uterine irritability as the chief complaint. Clear? Okay. Now, how do you manage patients of polyhydramnios during labor? See, as I told you just now, that whenever the membranes are going to rupture in polyhydramnios, the entire amniotic fluid is going to come out suddenly. And so what is going to happen? The size of the uterus will suddenly shrink, and it is going to lead to placental abruption. That is why during labor in a patient of polyhydramnios, I am going to do something which is called as a controlled ARM. Controlled ARM. What do you understand by controlled ARM? See, normally when you do ARM, first tell me what do you understand by the term ARM? ARM is artificial rupture of membranes. Right? Artificial rupture of membranes, it is done with the help of an instrument which is Cocker's forceps. Right? Now, when membranes rupture, prostaglandin E2 is released and the process of labor gets accelerated. So many times when my patient is not, the labor is not progressing, I will rupture her membranes with the help of Cocker's forceps so that prostaglandin is released and the process of labor gets accelerated. Right? Now, that is what is a normal ARM, a usual ARM, which is also called as amniotomy. Amniotomy. Now, please remember that ARM or amniotomy is contraindicated in polyhydramnios. I am not going to rupture randomly the membranes, right? I am going to do a controlled ARM. In a controlled ARM, I am going to make holes in the membrane using needle and syringe. Using needle and syringe. Just write it down and let me explain. So, suppose you are sitting in an emergency and at night a patient comes to you with BPH. An old man comes to you with BPH and he is unable to pass urine. The bladder is full. Right? Now, so many times you would have noticed that immediately when you put a Foley's catheter, what happens? When you put a Foley's catheter, the urine comes out suddenly, and because the urine comes out suddenly, the bladder, it decreases in size suddenly, and because of which there is hematuria. Because of the sudden decrease in size of the bladder, there is mucosal injury and there is hematuria. Right? So your seniors tell you this, definitely who've got clinical experience, they are going to tell you the solution for it. And that is, they say that do not empty the bladder suddenly. So for that, what you have to do is when you put a Foley's catheter, the urobag has to be held at a little height. So keep the urobag at a little height so that, when the urine comes out, this urine comes out it is just dribbling of urine. Urine doesn't come out suddenly. Now, because urobag is at a height, urine is going to come slowly. The bladder is going to empty slowly, and slowly the size of the bladder will decrease and hematuria will be prevented. Same principle we apply here. We do not do artificial rupture of membranes where with the help of Cocker's forceps, you are just nipping the membrane. Here we are going to take a needle and a syringe, and we are going to guide the needle with our fingers, and we are going to make tiny holes in the membrane. And from those tiny holes, amniotic fluid is going to come out slowly, and slowly the size of the uterus will decrease, and that is going to prevent abruption from happening. Right? So in patients of polyhydramnios, if they come to us in labor, you have to go for a controlled ARM. Normally done ARM is contraindicated. Now this is so easily said that done. Why? Because when you are going to actually do this procedure, you will see that membranes are very tensed. Because of amniotic fluid, the membranes are very tense. And the moment you, make a hole in the membranes, suddenly the membranes burst. And suddenly the amniotic fluid comes out. Now what am I going to do? Now I'm going to take a gauze piece, and with my hand I am going to close the vulval outlet. With my hand I will not allow amniotic fluid to come out suddenly. With movements of my hand I am going to see that only little bit of amniotic fluid comes out. So I will see to it with the movement of my hand that amniotic fluid comes out gradually and not suddenly. Right? So that is what is controlled ARM. Now, timing of delivery. Now, if you have, as I told you, whether it is moderate or severe polyhydramnios, that all these are high-risk pregnancies, and I have to do induction of labor. So in mild to moderate polyhydramnios patient, I am going to go for induction of labor between 39 weeks to 40 weeks plus 6 days. And in severe polyhydramnios, I am going to go for delivery at 37 weeks. That means induction of labor at 37 weeks. I am going to start the process of labor in these patients. In mild to moderate polyhydramnios, between 39 to 40 weeks plus 6 days, and in severe polyhydramnios at 37 weeks. Clear to all of you? Yes? Any confusions on polyhydramnios? No? So if no confusions on polyhydramnios, let's continue with oligohydramnios. Now, what is oligohydramnios? Again, the definition for oligohydramnios is if AFI is less than equal to 5 centimeters, if single deepest pocket is less than equal to 2 centimeters, or if the absolute value of Liker is less than equal to 200 ml. Most common cause of mild oligohydramnios, again, it is idiopathic. And most common cause of severe oligohydramnios, again, it is congenital anomalies of the fetus, and this time it is renal anomalies of the fetus. So common sense tells me that yes, if there is renal anomaly, there is going to be decreased urine output, and because of which there is going to be oliguria or anuria, and because of which there is going to be oligohydramnios. Right? So the causes of oligohydramnios, number one mechanism is congenital defect of the renal system. So if there is a congenital defect in the renal system, that can lead to oliguria, and that is going to lead to oligohydramnios. And congenital defect is seen, it could be due to renal agenesis, it could be due to cystic disorders of the kidney like polycystic kidneys, it could be due to obstructive disorders like posterior urethral valve. Right? So congenital problems, they could be obstructive in nature. It could be a case of renal agenesis. It could be a case of polycystic kidneys. Now, over here, I have told you again that fetal urine production happens at 12 weeks. Therefore, kidney disorders, they cannot lead to oligohydramnios in first trimesters. They can lead to oligohydramnios in second and in third trimester. And the most common time for oligohydramnios due to renal defects is second trimester. Right? Is this clear to all of you? Okay. Next problem because of which, they can be oligohydramnios is rupture of membranes. If membranes are ruptured, obviously the amniotic fluid is going to come out. And if amniotic fluid is going to come out, it is going to lead to oligohydramnios. Now again, membrane rupture can lead to oligohydramnios in second trimester or in third trimester. And the most common time for oligohydramnios due to ruptured membrane is third trimester. Right? Third reason for oligohydramnios could be due to decrease in urine production due to uteroplacental insufficiency. Now, whenever there is uteroplacental insufficiency, that means because of the placenta, because of this, when placenta is getting less blood, placental insufficiency means placenta is getting less blood. Now, if placenta is getting less blood, it is going to give decreased blood to the fetus. Right? So in uteroplacental insufficiency, there is going to be decreased blood to the fetus. Now, when there will be decreased blood to the fetus, there will be decrease in renal blood flow. And because of decrease in renal blood flow, there will be decrease GFR, and that means there is going to be decreased urine production and oligohydramnios. Right? Now, uteroplacental insufficiency is seen in case of maternal PIH. So, if mother has pregnancy-induced hypertension or if there is intrauterine growth restriction in the fetus. Both these are causes of uteroplacental insufficiency. I just need to explain to you just a small bit over here. So, if mother has PIH, that means BP in the mother is increased. Now, in our class 12, we had studied that pressure and volume are inversely related. So, when BP in the mother is increased, volume of blood which is going to the placenta will decrease. Right? So, volume of blood going to the placenta decreases, and this is what is called as uteroplacental insufficiency. And just now we saw that whenever there is uteroplacental insufficiency, there will be decreased blood to the fetus, and because there will be decreased blood to the fetus, there will be decreased renal blood flow. That is going to lead to decrease in GFR, and that is going to lead to oligohydramnios. Right? So, maternal PIH can lead to oligohydramnios. What about IUGR? Now, in IUGR, again, IUGR means that it is happening, the fetus is getting less blood. That is why its growth is less. So, fetus is getting less blood. And that is why fetal, right? That is why fetal growth is less. Now, when fetus gets less blood, it has a brain sparing effect. What is this brain sparing effect? What does fetus do? Fetus collects blood from all the other organs and sends it to the brain, because fetus knows that one organ which has to be protected is the brain. So, because of the brain sparing effect, blood from all organs goes to the brain. So, same thing is going to happen to kidney also, that blood from the kidney is going to go to the brain. So, there will be decreased renal blood flow. And when there will be decreased renal blood flow, there will be decreased GFR. And again, that is going to lead to oliguria, and that is going to lead to oligohydramnios. Have you understood? So please don't mug up things. You just understand, and everything is so very, in OBS, very rare things, very few things have to be mugged up. Rest OBS is only and only understanding and concepts. If you are clear, OBS and gynae is actually nothing. In OBS and gynae, if you are understanding the concepts which I am telling you during videos, if you get 35 questions, out of 35 questions, I can guarantee you that you will be easily able to answer 32 questions. Right? That is a guarantee. But then you have to understand the concepts, and you should know how to apply those concepts. And for application of the concepts, you will have to practice MCQs. Right? Okay. Now, remember that uteroplacental insufficiency, it leads to oligohydramnios in third trimester. So, when membrane rupture leads to oligohydramnios in third and second trimester, more common is third trimester, and uteroplacental insufficiency also leads to oligohydramnios in third trimester. Then comes post-term pregnancy. I told you that when pregnancy continues more than equal to 42 weeks, there is oligohydramnios. This also you know. Then torch infections. Why in torch infections? In torch infections, there is calcification of the placenta. And because of placental calcification, there is oligohydramnios. And I told you torch infection is one of those reasons where you can get oligo and poly, and more common is oligo. Right? Oligohydramnios is more common than polyhydramnios. Then I also told you there are certain drugs which lead to oligohydramnios, ACE inhibitors and endomethacin. Right? And obviously, if the placental abruption is happening, there won't be any filtration which will happen across the placenta. So, placental abruption also leads to oligohydramnios. Right? So, these are all causes of oligohydramnios, which you will have to remember. I mean, even if you've understood, even if you don't mug up these causes, when you will look at the list, you will understand that whether that particular cause is leading to oligohydramnios or not. Now, this is one ultrasound again where I want you to see that how OBS and radiology can be integrated. Now, in this ultrasound, what you are seeing, what is this typical sign called as? This typical sign is called as a keyhole sign, where you can see a distended bladder. And this is seen in posterior urethral valve syndrome. In posterior urethral valve syndrome, you get a keyhole sign on ultrasound. And in the mother, what are you going to get? In the mother, you are going to get oligohydramnios. Clear? Now, what are the consequences of oligohydramnios? If there is mild oligohydramnios, there is no consequence. Mild oligohydramnios will not lead to any consequences. But if oligohydramnios is moderate to severe, and moderate to severe oligohydramnios is happening in first trimester. See, what was amniotic fluid doing? Amniotic fluid was distending the uterus so that the fetal parts get space to grow. Now, if in first trimester oligohydramnios is happening, fetal parts do not get enough space to grow, and that leads to pulmonary hypoplasia. Pulmonary hypoplasia, or it can lead to limb amputation. Right? More common is pulmonary hypoplasia. This is going to happen when oligohydramnios happens in first trimester. Now suppose oligohydramnios is happening in second or third trimester. Now if oligohydramnios happens in second or third trimester, by that time organogenesis is complete. Right? So I will not get pulmonary hypoplasia, I will not get limb amputation, but problem remains the same, that there is less space. Now because of less space, there can be limb deformities. Like there can be club foot, or that is what is CTEV. Right? So, because of less space, if oligohydramnios is happening in second or third trimester, it will not lead to limb amputation, but it is going to lead to limb deformities. Right? Other than that, it can, because of less space, there can be cord compression. Cord of the baby can get compressed. Now, if cord of the baby gets compressed, it leads to fetal distress. And just now I told you that whenever there is fetal distress, fetus is going to pass meconium in amniotic fluid. Right? That is how we get meconium stained amniotic fluid. And I also told you that fetus swallows amniotic fluid. So this meconium stained amniotic fluid fetus is going to swallow, and that is what is meconium aspiration syndrome. Right? So remember that oligohydramnios in first trimester can lead to pulmonary hypoplasia or limb amputations. Oligohydramnios happening in second or third trimester can lead to limb deformities. It can lead to cord of the baby getting compressed, because of which there can be fetal distress. And that is why I told you it's a high-risk pregnancy. Right? Because oligohydramnios can lead to cord compression. Now, although I have not taught you CTG just now, but if you know anything about CTG, tell me just one question. Whenever the cord of the baby gets compressed, what is the most common CTG finding which you get? So whenever the cord of the baby gets compressed, you get variable decelerations. Variable deceleration on CTG. Again, that's a very important finding question. So if they ask you what is the most common finding which you get, CTG finding which you get in patients of oligohydramnios, you are going to get variable deceleration due to cord of the baby getting compressed due to less space, right? Then there is one syndrome which you have to remember, and that is Potter's syndrome. There are two syndromes which I'm going to tell you related to oligohydramnios. One of them is Potter's syndrome. In Potter's syndrome, there is severe oligohydramnios plus a kidney defect like polycystic kidney or renal agenesis. So because of polycystic kidney or renal agenesis, there is severe oligohydramnios, and this is going to happen in first trimester. Kidney defect is going to happen in early trimesters. So there will be lung hypoplasia and typical facial features like flat faces. Right? So if what is Potter's syndrome? In Potter's syndrome, you get severe oligohydramnios, which is happening due to a kidney defect like polycystic kidneys, like renal agenesis. Along with that, there is lung hypoplasia, pulmonary hypoplasia, and typical facial features like flat faces, which are happening because of the less space. So if you have a fetus who has pulmonary hypoplasia, who has a kidney defect, there is severe oligohydramnios, and the baby has a flat faces, that means we are dealing with Potter's syndrome, right? Okay, then if they show you this image of the baby and they say that what do you think was the likely cause in the mother which led to this defect in the baby? So tell me, what is this defect in the baby? This defect in the baby is club foot, or that is CTEV, right? And what is the problem in the mother which led to this club foot? Mother must have had oligohydramnios. Right? So this is how you are going to apply the concepts which I have told you in oligohydramnios linked to and link them to your questions. Then they can show you this defect. Now, this defect, what you are seeing over here, what you are seeing is that there is amputation of the distal part of the limbs, digital amputation. Can you see? Digital amputation, right? So this is called as constriction band syndrome, amniotic band syndrome, or this is called as Streeter's syndrome. So one syndrome which you get in oligohydramnios is Potter's syndrome, where there is kidney disorder along with severe polyhydramnios, along with pulmonary hypoplasia and typical facial features. And then you have another syndrome associated with it, which is called as amniotic band syndrome or constriction band syndrome. Now, what happens over here? This is seen when the membranes rupture. Now, when membranes are going to rupture, the entire amniotic fluid is going to come out. So there will be severe oligohydramnios, and the membranes, they are going to tightly wrap themselves around the fetus, causing constriction bands or constriction rings. So the membranes are going to wrap tightly. So can you see over here in this image, I want you to concentrate on this image. In this image, if you see closely on this finger, you will see as if a rubber band like thing is tied, right? So this is what is a constriction band, which is made up of these membranes which are tightly tying themselves around the fetus. So that there will be decreased vascular supply to the part distal to the ring, and this happens most commonly in the digits. So in case of constriction band syndromes, there will be digital amputation. So distal part of the limbs get amputated. There is digital amputation, most commonly which is associated with constriction band syndrome, or you may get craniofacial anomalies, but that is less common. So over here you are getting distal limb amputation. So distal limb amputation or digital amputation is seen in constriction band syndrome or amniotic band syndrome, or what is called as Stritter's syndrome. Yes? Now, how do you manage oligohydramnios? As I told you, oligohydramnios, when it is moderate to severe, it is a high risk pregnancy. Why it is a high risk pregnancy? Because of increased chances of, due to increased chances of fetal distress. So that is why you have to go for fetal monitoring. How are you going to do fetal monitoring? Number one, by doing non-stress test weekly. Number two, by doing biophysical profile or biophysical score weekly. Number three, because in patients of oligohydramnios, one of the very common reasons for oligohydramnios is uteroplacental insufficiency. So I am going to follow them up with Doppler of umbilical vessels. Right? So what fetal monitoring has to be done? You are going to do NST weekly. You are going to do biophysical profile weekly. And because one of the very common reasons for oligohydramnios is uteroplacental insufficiency, for uteroplacental insufficiency, you have to do a Doppler ultrasound of the umbilical vessels. Right? Termination of pregnancy in case of oligohydramnios, if there are no complications, if it is mild, then it has to be terminated at 39 weeks. But if complications are present or if it is moderate to severe, or if complications are present, then between 36 weeks to 37 weeks plus 6 days. If it is mild and no complications are present, then 39 weeks. Now, for oligohydramnios, for managing oligohydramnios, what can I do? For managing oligohydramnios, I can tell my patient to improve her oral hydration. And number two, I can go for amino infusion. Now, amino infusion means you are going to instill normal saline into the amniotic sac. But there is only one indication for amino infusion, and that is if you are getting recurrent variable decelerations due to oligohydramnios. So you were doing NST weekly, and when you did NST, you saw that you were getting recurrent variable decelerations. Then only I'm going to go for amino infusion. Have you understood this? Right? So in patients of oligohydramnios, you have to go for fetal monitoring, which you are going to begin at 32 weeks. And after 32 weeks, you have to do weekly NST, weekly biophysical profile. You also have to go check their Doppler umbilical artery ultrasound. Then you are going to tell the mother to improve her oral hydration and recurrent variable decelerations. Then only I'm going to go for amino infusion. And termination of pregnancy if it is mild oligohydramnios at 39 weeks. If it is moderate to severe and complications are present, then between 36 weeks to 37 weeks plus 6 days. That means induction of labor has to be done between 36 weeks to 37 weeks plus 6 days. So the diagnostic evaluation in moderate or severe oligohydramnios and polyhydramnios. So there is moderate or severe polyhydramnios, moderate or severe oligohydramnios, right? So in this case, the first step always is rule out gross congenital anomalies by doing ultrasound, right? Now, if gross congenital anomalies are absent, and if they are present, the next step is karyotyping. If gross congenital anomalies are absent, then the next step depends upon whether we are dealing with oligo or whether we are dealing with poly. In poly, the next step is rule out maternal diabetes by following Dipsey criteria, right? If this is negative, rule out fetal anemia. How are you going to rule out fetal anemia? By checking the peak systolic velocity of middle cerebral artery on middle cerebral artery Doppler, right? Now, in case of oligohydramnios, rule out premature rupture of membranes. If this is absent, then rule out uteroplacental insufficiency, which you do by umbilical artery Doppler. On umbilical artery Doppler, you have to see the SD ratio. You are going to check the SD ratio on umbilical artery Doppler to know about uteroplacental insufficiency. Now it is clear to all of you. Take care. Bye-bye.